July 21st, 2020 at 4 o'clock p.m. This is Betty Ann Middleton, the presiding chair from Elmore County. I'm one of two Elmore County representatives. I just thank you and welcome everybody for participating today in this, once again, important meeting. I will now take the roll call for the counties, starting with Valley County.
This is Commissioner Hasbrook. I'm present.
Ada County.
Ted Epperly, present.
I'm sorry, Jane Young.
Yes, present.
Diana.
Commissioner Laciando, present.
Okay, thank you. Boise County.
Commissioner Sturm, present.
Thank you. And Elmore County, Representative Blanksma. I don't think Megan's on. Okay, moving on. We do have a quorum, so moving on to our action items. I'll ask our director, Russ Duke, are there any changes to the agenda, Russ?
No changes, Madam Chair.
Okay, thank you. All right, item number 4 is under new business. Number 1 is we need motion to approve our minutes from the July 14th, 2020 board meeting.
Madam Chair, this is Commissioner Hasbrook. I make a motion that we approve the July 14 minutes.
I'll second.
Thank you,
Commissioner
Al.
Sturm.
Thank you, Ryan. Okay, we will take a roll call vote on the approval for those minutes, starting with Valley County.
Commissioner Hasbrook, aye.
Ada County. Jane Young.
Jane Young, aye.
Ted Epperly.
Ted Epperly, aye.
Diana Laciando.
Commissioner Laciando, aye.
Boise County. Commissioner Sturm.
Commissioner Sturm, aye.
Elmore County Representative Blanksma. I don't believe she's on the call, so the motion, having no votes, the minutes for our July 14th meeting do stand approved as presented. Moving on to number 2 is a COVID-19 perspective from Treasure Valley's largest primary care system. And Dr. Peterman, we much appreciate your joining us today, and I'll turn this over to Russ to do an introduction for you.
Thank you. I'll just go ahead. Well, first of all, very gracious of you to invite me and allow me to share some of our data. But more important is I want to thank you for the action you took a week ago. It was not the easiest action for you to take, but as a healthcare provider, I couldn't have agreed with you more strongly, and you don't get thanked for the job, and I'm thanking you. So I'm going to try and share my screen here and pull up my presentation. And my plan is to go through the slides quickly and then answer any questions, because I know you guys are very busy and have a lot of different things to cover. So just in summary, we have 19 clinics throughout Canyon and Ada County. Most of our testing is done in Ada County, so the numbers you're looking at here represent 75–80% in Ada County. And if you look at all the testing that's been done in the Valley, at various times, Primary Health does anywhere from 35 to 45% of all the testing. So what you see here on the bottom, that's the number of tests we've done per, I believe, yesterday. And here's the positive. The current positive rate of 9.6 goes back to the very start, the beginning of March. And at the low point, following quarantine at home, that rate was down as low as 2 or 3%. So obviously, big change. This one looks at the positive rate per day. It's got a lot of numbers on it, but here's the total tests done for that day. Here's the negatives. Here's those not resulted. And if you look in here, we have a lot of results to come back. Just 60 seconds ago, I just got an email of 21 positives that will be somewhere related to these, the 17th and 18th. And if you just look, you can see here the positive rate per day. It's 15, 17, 13. And this one at 11, which is the most recent, we have so many to report, this likely will go up, particularly since I just saw the 21 positives. So we'll look at the next slide. Yeah. So this is a better sense of what's going on. This is the positive rate per week. And so over here, this was the high point in the end of March, beginning of April. This is when Blaine County, the hospitals had their highest admissions, and the positivity rate was only 5%. Here's after June 7th, the bars were somewhere in here, and here you begin to see what has been a consistently high 15% positivity rate. This is a little lower because we don't have all the data. Again, as I said, I just got 21 positives. This likely will be up at 15%. And I believe it's accepted by epidemiologists and those infectious disease specialists that are involved with epidemics, that you have an epidemic under control when the positivity rate is 5% or less. If the positivity rate is greater than 10%, most believe you're not testing enough. That is, that there's more out there that are positive you're missing. This is a really dramatic slide. Again, here's April, the peak, when we had the most admissions and the most cases, and we were sheltering at home at that time. Then here's when the governor moved to stage 4 or stage 3, and then the frequenting at the bars, and this is just an unbelievable surge. And again, it continues. Again, this number just represents we don't have all the results. Same with this one, but this is just an enormous surge of cases, absolutely frightening. And thank goodness you guys took the action to encourage masking, to mandate masking for all of Ada County. This slide's a little bit more complicated, but I think it tells a lot. Again, over here on the left, March, April, all these numbers are lower. These are actually cases per week based on age group. Blue being less than 18, those are the kids. Orange, 18 to 39, then 40 to 59, and then the yellow, we're not gonna say which group I fall into, but most likely the yellow. In any event, as you get more to the right and the more recent data, this yellow is the most concerning. Here's where you have positive cases of people over 60, literally 1 or 0 per week, and we're all the way up to 36, and I don't have all the data. This leads to the admissions to the hospital, and this is the most concerning. And it's continuing to go up. It's not slowing. The other interesting part of this, which is what I'm going to end on and what I want to leave you with to think about, is the blue, which is the kids. And again, look at throughout all of this, hardly any cases per week, 1, 0, and now we're up to 50 cases per week. And again, we'll talk more about this, but not only because I'm a pediatrician, but because I believe of its impact, and particularly as it relates to schools, it's a very worrisome number. Then this is even a more dramatic example of what the concern is with children. So the gray is what the percentages were before we had this recent surge. And again, it's under 5, 5 to 12, 12 to 18, 18 to 40, and on up. In almost every category, you can see how high it gets. But in here, this is the concern. These are the teenagers going to school. These are the elementary. This 11.7 of this age is very concerning. And the reason it's so concerning is, I don't know if you saw, but is a recent large study from South Korea, and there's a lot of questions about children and coronavirus, and I can certainly respond to those. But that particular study, which just came out, said this age group had the infectivity equal to adults. That is, they are just as likely to pass the disease on to another person as an adult would. And then if you look at that positivity rate, again, remember what I said, 5% or less, you have a control. Now we're over 10%, and we're talking about going back into schools. That is a very, very, very concerning number. That is essentially my presentation. And let's see, I'll stop sharing my screen there. There we go. And I can answer any questions or elaborate on my concerns about schools.
Madam Chair. This is
Yes,
Commissioner.
go ahead.
Dr. Peterman, so 2 weeks ago, I believe it was, we had Dr. Souza on here, and one of the things we discussed was just the testing and the testing strategy. And for our board, and certainly for those watching, just to reiterate what the Board of Health and Central District Health have at our fingertips. The REST's team receives the reports, they do the contact tracing, they do the education, and then we have the opportunity as a board to implement restrictions if need be. But we don't control testing. And so as you know, we're seeing these positivity rates get high and hearing wait times. I'd love to hear kind of your reality of what's happening in terms of access to testing at primary health and what needs to be done. Just some perspective from the boots on the ground.
Yeah, so I want to say 2 to 3 months ago, the CEOs of West Valley, St. Al, St. Luke's, and those that outlying hospitals invited myself and one of the other physician CEOs to meet or to communicate weekly. And because of those communications, I have a sense of the challenges they're having similar to ours. So as relates to testing, the demand for testing up till this point has been best described as overwhelming. That is, both hospitals have now limited who they will test, and in fact are no longer testing asymptomatic contacts, which is if you go back to the governor's task force of testing, asymptomatic contacts was in tier 1, tier 2. And so what I to give you a sense of that is that it's not just testing materials that are the limiting factor. A greater factor is staff. And I don't think this is something that the public, or that matter, the national media, or maybe yourselves are aware of. The strain on staff so that even if you did have enough testing equipment, you can't test everyone. As relates to primary health, we don't have limits on testing equipment. My understanding is both St. L's and St. Luke's have problems with reagents. And the other issue is they just don't have the staff. They don't have the time to, in a sense, focus. They're a hospital. And so they have had to turn people away. Does that give you a sense of it?
It does. I think if I might follow up,
Yes,
how long is it taking for you to get results back? Because it seemed like in totality, things had sped up quite a bit, and now it's taking longer again as everybody's kind of fighting for space with these different labs. Could you
Yeah,
give
so
us a sense of that?
St. Luke's and St. L's both have the machines to do testing, and in a sense, a 24, 36-hour turnaround time. Those machines, again, I'm using their information to me, are being used to capacity to manage their own patients, their own staff, those patients that are requiring surgery. And so they are both sending out to outside labs. To give you a sense, one of the outside labs that is used is Quest. Their turnaround times are over a week, and in some aspects, 10 to 14 days. We use 2 outside labs. One, we have a turnaround time of 24 hours. It's a lab out of Oregon, and so we're moving all our testing to that lab. So for us, we have a 24, 36-hour turnaround time. We also use as a backup LabCorp, and initially they're out of Seattle, Arizona. They initially were 24, 48 hours. They're now 4 days. And the backup is, as you can imagine, is compounding, because these national labs are getting more specimens from Arizona, California, Washington, and Idaho.
So Betty, I guess maybe I would punt it over to Russ at that point. If it's taking in some cases 4, 6, 10 days for someone to get a positive result, in the meantime, are they potentially infecting people? We don't know. Could you kind of speak to that?
Yeah. So, in a sense, a turnaround time in a week, I would describe as close to worthless, because the people, if you're, let's just sort of play this out. If you're very sick, I mean, you're short of breath, you're going to go to emergency room, or if you come to primary health, we're going to evaluate you, and you need to take action right there, no matter what the test results is. But if you're someone who has mild symptoms, or you're asymptomatic and you had a contact and you can't get results, and you have a job, you probably are going to continue to go to that job. So the implications are not good. Again, remember, I described for Ada County a positivity rate of over 15%. That in itself tells you there is tremendous spread going on. As high as, depending on your age, the positivity, I mean, 34% of those that have it may be asymptomatic, depending on the age.
Thank you.
Madam Chair, this is Commissioner Hasbrook.
Yes, go ahead.
Dr. Peterman, I guess the big question that I have is, because, we live up here in the sticks and we're kind of rough and rowdy, a lot of folks think that this is really not that serious of an issue. Is there any more thought or discussion about, we can see how many people have died, but we don't know their age. We don't know, if it's middle-aged, young people, old people. And I think we're really missing the boat on not getting that data out to kind of scare these younger folks into, hey, this is a real concern. Do you have that concern, or am I just...
Yes, no. I'm short of me getting a truck with loudspeakers, driving around, renting billboards. Yeah, it's an enormous problem, and it starts with national leadership. I mean, put aside the politics, but if the communication nationally is confusing or suggesting it's not serious, then it's very, very challenging. Second is, as relates to me personally, and I would also say the other CEOs of the hospitals, we have tried to get the word out. I mean, I'm on TV a lot, not because necessarily I'm interested in that aspect, but I'm trying to get the word out. My sense is, as a pediatrician, maybe hopefully I'm more believable. The other aspect of it is it becomes patient to patient. At primary health, we see close to 1,500, 2,000 patients a day. You can't come into any of our offices without a mask on, and I could send you emails that describe disruptive people, and we will call the police if we have to, and that's when we sell the message. But you're absolutely right. My wife and I have a place in Garden Valley. they just, they think Mary and I are kooks because we're wearing masks. Yeah, it's very disconcerting. Again, I'm going a little bit beyond, but with school starting and with what you just described, and given the data we have, which is real data, this is very concerning. I worry three things. One, there will be kids that will get ill, and there will be kids that will need to be hospitalized. Two, there's no question the kids will be the index case and they will spread it. And we have evidence for that from our data. And three, I believe there are going to be some teachers who will be too frightened to come to schools, or you begin to infect the teachers. You have a limited number of teachers before it impacts the school. At primary health, and I apologize, Diane, I didn't respond completely. Again, what we're seeing is, as relates to testing in our clinics, right today we have 21 of our staff out. Now, we do have around 600 employees. That doesn't sound like a lot, only 3%. But if you're primary care, and in a sense, you only have so many to work 12-hour shifts and work weekends, we've had to close a clinic because we don't have staff. So again, when you think about asymptomatic carriers, you think about kids now congregating in classrooms, and you have the commissioner talking about people not wearing masks. It's very concerning.
Madam Chair, I have a follow-up.
Madam Chair? Oh, go ahead.
Sorry,
Yes,
Jane.
go ahead.
If these young kids are getting sick from it and then getting better, is there a concern about them being infectious to the other folks? I mean, certainly there's got to come a point in time when everybody's probably going to be exposed to this virus, and either it's going to build, immunity to it, or they're going to not make it. I mean, is there a light at the end of the tunnel at all on any of this?
Yeah, I think Russ mentioned this before when I've listened. You're asking the right question. Herd immunity, which is where we reach a point where enough of the population has either been exposed or had a vaccine and the community's protected. That's at 70%. We're at, I have a positivity rate of 15%, but the number of people who actually have this is probably closer to 5 to 7% for Ada County. So we're not even close. And yeah, I mean, looking at the graphs, putting aside opinions, politics, just looking at the graphs I showed you, there isn't anything there that should give anyone comfort. It should make everyone worried. And if you're at the extremes, the very young, or you're older, you're vulnerable. And then again, there are cases, St. Luke's and St. El's have cases of 20-year-olds in the ICU.
Thank you for your answer, sir.
Oh, thank you I'm thrilled you would ask me to present our information.
Well, I just feel
Jane,
like we
did you
got
have
to
a question
start
for Dr.
thinking
Peterman?
about, what are we going to do with these
Al.
schools? Because I think that's going to be the next big hurdle
Well,
with schools.
Yeah, just as an aside, I think you're all familiar with Dr. David Pate, the former CEO of St. Luke's, and frankly, he's been his wife wants him to go back to work because being retired, he doesn't have time for his grandchildren or for her. So, and he doesn't get paid anything. So, and I call him sometimes 3 or 4 times a day. But he and I are actually going to spend some time tomorrow to try and figure out a strategy to communicate with school boards. It doesn't help to scare people, just as you've mentioned. I mean, that just doesn't work. It's better to give them information, and hopefully they come to the conclusion. I mean, separate from the fact, my opinion is the positivity rate is too high for schools to open. But what the schools need for opening is, what is their plan to get the children to school? What is the plan in terms of timing to keep children not close in the halls? What is the plan in the classrooms? What is the plan with the teachers? What if a teacher gets ill? How are you going to handle index cases? How are you going to handle resource? How are you going to handle lunches? There are so many aspects of this, and it's a lot to ask of the schools. Yeah, I'm concerned.
Betty
Madam
Ann,
Chair,
this
this
is
is Jane.
Yes, Jane, go ahead.
Dr. Peterman, thank you very much for all the information. I'll tell you, it's an education unto itself. I was wondering about the quick test that our providers have gotten, and they understand the results in the next hour, what the validity is or the reliability of the test itself.
So we should start from the standard PCR test, which has been accepted across the country as the most accurate test. No, that's not the most accurate. I mean, that test in itself has its own set of problems, but we're accepting it as the best test. Having said that, the Abbott test has been reported anything as high as a 30% false negative. That is, 30% of those who actually have it would be a negative test. So because of that, St. L's, St. Luke's, for that matter, Salzer, I'm not sure how much they're using, and we, Primary Health, have been hesitant to use it. We have it. We're stockpiling it for the very reasons, what if we need it? What if someone needs a result in 15, 20 minutes? The test takes 20 minutes. But it just, in our community, it's not been accepted as a reliable test. So for example, if a patient has a scheduled surgery with St. Luke's and St. L's, and we do an Abbott test, they won't accept it. So at this time, what we're doing is we're holding it. If for some reason a individual, it makes sense that they need an immediate test, then we will do it. But right now, because we're using this lab from Oregon, and they're using the same machines that Luke's and L's are using, and we can get a test results in 24 hours, we feel pretty good that we can give people information right away.
Thank you.
Any further questions for Dr. Peterman?
yeah, Betty Ann, this is several.
Yes, Ted, go ahead.
David, thank you for the presentation. It's very helpful. I agree with you in regards to the high positivity rates and the impact that will have not only on our community, but on our schools, as you're alluding to. So the first of 4 questions I have for you, David, especially as a pediatrician, is just imagine the scenario in October, November of the roller coaster that principals and teachers are going to face when they've got 30 kids per class and many viruses of multiple types, from rhinovirus to adenovirus to respiratory syncytial virus, along with potentially early emerging influenza, as well as COVID-19, are in the classrooms. And we've got kids with runny noses, we've got kids with coughs. You and I have seen thousands of them over the course of our careers. And what is the teacher, what is the principal, what is the school to do? If we do not have the ability to rapid test, which is going to be limited, which is already overwhelmed as you're reporting, I don't know any way out of that schools are going to have, other than it's just going to be a chaotic roller coaster. So David, as a pediatrician, if schools do reopen and we get into the fall and we get into viral season, how do you see this playing out in the schools?
Yeah, I was hoping we would get by without your questions, Ted. I knew that they would be hard. And again, your board is well served by having Dr. Epperly on your board. First of all, Ted, this is the reason I feel so strongly that schools should not open, until we get the positivity rate down to 5% or close to that. Because without that, you're right. As you get into the fall, November, December, you can't. There's just no way to manage this. The second thing is particularly primary health, because we're primary care, and your association with a family practice residency, we are already making plans for how will we evaluate these children. That is, you will have so many children with fever, so many children with other coughs and other symptoms. How do you see them? How do you examine them safely and then make decisions? And at some point, which is a little scary, but at some point from the physician side, you're going to have to make decisions based on clinical symptoms, and you're going to have to also make decisions based on severity of illness, because you're absolutely right. There will not be enough testing equipment. And so I come back to what I originally said, which is it is so important to get the positivity rate down today. And the second part, the schools have to have mapped out what they're going to do in all the scenarios that you just described. Otherwise, yes, I predict chaos.
Madam Chair, this is Diana.
Yes. Ted, were you through?
A couple more, but if Diana wants to jump onto this question, I'll come back to mine.
Okay.
Thanks.
All right,
Thanks,
Diana,
Dr.
go
Everett.
ahead.
So I want to ask another hard question, and especially because you're a pediatrician and I know you deal with and think about these things. During home order, we saw some really unfortunate side effects related to increased child abuse calls, increased domestic violence, etc. And I know one of the things the schools are struggling mightily with, and truly this is a no-win situation, obviously, but is knowing how many kids rely on them for being that safe place in their life, for being that place where they have access to food, for being that place where they have mental health support. And I guess, I know the American Academy of Pediatrics has sort of gone a little bit back and forth on this as things have evolved. But we are not here to make those schools decisions. And I think in our next action item, we'll kind of talk through what that process looks like and have Russ lay that out for us. But I'm just interested in your opinion as a pediatrician, weighing all those things and knowing that those social determinants of health are so critical too.
Yeah, Diana, you couldn't be more correct. First and foremost, kids need to be safe. You and I, we all agree with that. The second is they absolutely belong in school. And I think that the best way to describe the situation, I would say, this is a small sample, but 98% of the mothers who I've seen in the last 3 to 4 weeks either say, is it safe for my child to go to school, or what should I do? But 98% say, I want him to go to school, but I'm concerned. And that's the right approach. I agree with that. That's exactly the approach we need to take. So it would be these steps. The first step would be, I believe the positivity rate needs to come down. It at least has to be decreasing. Of course, I'd like 5%, but I'll accept less than 10%. The second aspect of that is detailed plans for the schools. And so now you at least have a fighting chance. You have some statistics in your favor, which is, it appears, and Ted is aware of this also, it appears those 5 to 12-year-olds, when they get coronavirus, they seem to be less ill. There is some data to support that. And there may be, I only say may because there's just as enough, that may be that those younger children have less infectivity, that is, they infect less. So if you start with bringing the positivity rate down for the whole community, and you have detailed plans which address some of the issues that I just described, and you probably need to use some distance learning, or you know, it's with Boise and our here with such great weather, so much of the fall. Frankly, there could be a lot of teaching outdoors, and we know that's safer. So I guess I say that I'd rather the kids are in school. They need to be in school. I support that 100%. And I just tag along with that is I want the teachers to be safe. I want the kids to be safe. And we do know how to do that. And they're smarter people than me who have recommendations. The American Academy of Pediatrics has a whole series of recommendations for the classrooms.
I'm also a mom who had to homeschool plus commission this past spring. There's a lot of us out there who are our own mental health is going to be challenged.
Well, you know, but I mean, again, if I could just throw this in there, don't take offense to the men on the commission, but since I've spent my life working with mothers, we'd be a lot better off if the lead politicians were mothers. I totally believe we'd be better off. And you can respond however you want.
Yeah, I would agree. Betty Ann, this is Ted again. If I can just follow up with a couple of questions.
Absolutely. Go ahead, Ted.
The other thing, and it's good for the board to know this too, is, and David, I'd like you to opine on this, is we know that with fall and winter comes cold weather. And so kids are going to start to go inside just like adults will too. And that's when social distancing becomes harder. We're closer together. And the question that I'm going to pose now, David, is, you know, for a long time, we've just assumed that droplet infection is kind of the way this has gone down, but more and more data is really starting to show that this could be airborne as well. Certainly we know that with nebulizers and nebulization, but you know, the cruise ships have shown us this, the naval ship has shown us this, they've been spread through air systems in closed settings. If we get a super spreader event in the sense of an asymptomatic child, an asymptomatic 10 to 18-year-old, and we know that, as you'd mentioned, this can be as high as 33%. I just really worry about all these closed, contained classes in the winter, air circulation, air ventilation, and I'd like you to opine on the status of your knowledge around airborne carriage through closed ventilation systems in winter in schools.
Yeah. Oh, yeah. Again, I'm not the world's expert on this. The World Health Organization with others have finally all agreed there is aerosolization. We know that, and what percentage is droplets and what is aerosolization? I can't tell you the percentage, but I don't think there's any question that that's occurring. Number two, there is good data, even indoors. You wearing a mask and my wearing a mask works. Doesn't have to be an N95, as long as you're not doing a medical procedure. So when you think of a classroom and kids, the American Academy of Pediatrics has recommended masks for children 5 years and older. I agree with that. And so the third thing is again, I mean, classrooms have windows, and there is an enormous impact with ventilation. I'm not suggesting that every classroom is going to have all their windows open and it's 40 degrees in the classroom, but Ted's right. You need to think about these things, which leads me coming back is if it's November, if it's January, what plans have the schools made which may require staggered starts in the morning, may require it every other day. There are also descriptions of breaking a classroom up into pods. And so the groupings come at different times. You have to think through these things with the idea, well, if there is a child who does have coronavirus, asymptomatic, are we really protected because we have masks? And the follow-up to that, which is so important, how are we going to treat the positives? So for example, the 7-year-old in whatever second grade class, who has he or she been in contact with? So you have to think in those terms, and then how are we going to follow up? And what will we do with the contacts? Do we isolate them? Do we test them? You have to think through all of these things. And again, there are experts, there is information available. Certainly, I would be happy to help consult on that if a school or whatever wanted that. So I think it can be done, but you have to prepare for it. I go back to really what Diana said. Homeschool, mothers and fathers who had to work, single or dyads, they were very quick to say, I'm not doing this again. I can't do this. And I get it. When my kids, they were really smart kids, I got them BSU students to work with them with math. One, because they were so smart, and two, I didn't have the patience. So I get that. So we need to be working towards getting the kids in school. I agree with that.
And again, my last question to David. David, last question for me. Today, this morning, again, both hospitals are, getting filled to capacity. St. Al's, 54 COVID hospital patients as of this morning. Yep. 95 at St. Luke's. St. Luke's is at St. Luke's Meridian. They have one bed after being on divert at St. Luke's Nampa. Twin Falls and Boise have some capacity, but they're at 130% of ICU capacity compared to last year at this time. So we're filling up, and it's not even fall yet. It's not even winter yet. And the other thing that's happening, and you alluded to this, but this is the focus of my question, is St. Luke's, as of this morning, has 235 people out because of COVID-19 related conditions. Now that can be the illness, it can be childcare related to the illness, it can be caring for a loved one related to the illness, etc. You alluded to 21 people being out at Primary Health of your 600. I have close to 20 people out for COVID-19 related issues as well. Now, skip this thing forward. We now are in school. We've got all sorts of stuff happening. We've got the churn in school, like we've described. We've got parents needing to either try to stay healthy themselves or to care for a sick child that could have nothing more than rhinovirus or a common routine virus, but obviously in the absence of immediate testing, we've just got to assume the worst. They get sucked into home care for a child. It just has almost a devastating effect on the economy. And I'm thankful as well that we've gone to masks because at least we can control what we can control, adults, kids, et cetera, et cetera. But in terms of, if you can play this forward again in your mind on the impact of the workforce, not sick individuals now, but just the workforce and its ability. You've already mentioned that you've had some problems staffing your clinics. Can you kind of, for the best of your ability, just so that we can start to wrap our heads around this, What does this look like in the fall, winter, when we're in the dead of this, and its impact on workforce?
Yeah, there's so much. Yeah, obviously, again, not surprisingly, Ted is absolutely right on. I would say a few things. One, we need the other health districts to follow your lead. So I haven't had much success with Southwestern. Again, the Canyon County rate in our clinics is 19% positivity, Ted. Very worrisome. And also, just as a side, we're seeing more older individuals in Canyon County as positive. So to begin with, I don't know what impact you have on the commissioners or the board members from Southwest, but it sure would help because of the intermingling if they would also adopt the masking orders. I understand the challenges with the politics. Number two, I don't know that we're at the point where, again, the politics are such that the governor would move the whole state a stage back, or the governor would require masks for the whole state. I'm just not aware of that. But from a health standpoint, oh my goodness, I would want to move our stage back now to protect the economy later. And so the point being is, I believe because we're in stage 3, 49 people can congregate as opposed to 10. And people can still, and correct me if I'm wrong, can still eat in restaurants inside. So those issues very much concern me today because it keeps that positivity rate high and makes it more challenging in the fall. The second, from what you said, the scenario, my assumption I know with St. Luke's and St. L's, they are making plans to address exactly what you've just described. And so we have started our meetings for how do we see adults and children with cough, fever, and shortness of breath in November. We can't see them all in cars, but we can't bring them inside exactly either, because then we'll have mixing and we'll be causing the index case to spread. So our healthcare delivery system has to start thinking in those terms, and we are. Whether we have all the answer to tell you today, we don't. The third thing is we will have to close clinics. Here we are in the summer, and Ted and I both are telling you in primary care we have staff out. Again, just to give you a sense of the challenges that will come in November, normally with our primary health clinics, we get about 1,200 phone calls daily, just normal calls. Since June, we're getting 20. So just think, how do we take care of our normal patients that are calling for, oh, gee, what's my kid's, does he need a shot for measles? I need a refill on my blood pressure medicine. But layer on top of that 1,500 phone calls, because every patient that has a positive test, they call back because, well, what should I do with my uncle? Or you said I was negative, but I have these symptoms. And all of that cascades and it overwhelms the system. And I can tell you, I just saw some data on our patients with chronic diseases, and their what we call care gaps, their follow-ups on their hemoglobin A1Cs and their labs, they're not where they should be. And that's because people are not able to come in. And so November, has a huge impact. So I guess my message would be, as much as you as board members can have an impact in the community, I'd rather you do it now so that the economic impact is lessened later, and we as healthcare workers can actually address the problems. So yeah, I think we're very concerned about the winter. I didn't exactly answer Ted's question, but I certainly gave you my worries, my concerns.
Thank you, Ted.
Betty Ann, I have one question.
Yes, Ryan, go ahead.
So, Dr. Peterman, I just kind of an interesting question for you, I guess, is what does this look like in a school setting, even if we have just one child come to school, asymptomatic or not, positive for coronavirus, and what does that look like for the school? Amount of effort that has to be put into that, what the transmission rate looks like for that one student, even if it's just one.
Yeah. So to give you an example, let's take an employer, a bar, because we've had this, or a restaurant. One employee is positive. Now you have to, in the case of primary health, we have what we call a CRT, our coronavirus response team, which is set up with nurse practitioners who have to now do all the tracing. So first of all, we have to assign the patient. So in this case, you'd have to have the kid either see his own doctor or get him a doctor to make sure the child's okay. Then you start the tracing, and you have to, first of all, identify who was exposed, and then decide who has symptoms, who needs to be tested, and who needs to be isolated. And so it could be that all the kids in that classroom and that teacher need to be isolated, depending on what kind of contact they had. And then as you begin to do the tracing, well, he was in the principal's office. Okay, who was in the principal's office? Well, it turns out the mother and father of so-and-so were there. How long were they in there? Were they in the same room? You begin to see what happens. It is enormous. So with a bar or restaurant, it could take us 3 or 4 days to track it all down, because as you can imagine, what happens with just our own employees, I don't know if Ted has this, we have 50 to 80, 90 phone calls of our own employees to our CRT team daily, asking questions. My neighbor had this. That's the magnitude of it. So if you did it in a closed place like a school, particularly health districts, let's take another example. Russ is certainly familiar where pertussis was identified in a daycare or a school. Oh my goodness. Central District Health has to send letters. They have to have your people do the tracing, and then you have to set up a phone system to answer all the calls. So, Commissioner, you asked the right question, and just one case in one school, it is, yes, it takes a lot of people to solve it and take care of it.
Madam Chair.
Yes, Commissioner Malchiando, go ahead.
So just as a point, in our next discussion item, I do want to ask us to go. I have a number of different questions I kind of want to tease out as it relates to schools, and maybe providing some clarity as we go forward, because I know his team has been working really closely with all of the school districts.
And Betty Ann, this is Ted. If I can just ask David Peterman one last question.
Yes, go ahead, Ted.
So David, again, thanks for the presentation and all the data, all the questions you've answered. So if we can just make you king for a day right now, what would you do? You're the king. What would you do with the schools in the Treasure Valley as they come to open in the next month or two? What would you do?
Well, I do, you know, the 2 or 3 things that I mentioned. Number one, I would not open the schools. I would want to see the positivity rate less than 10 and going down. Number two, I get it. School districts are all unto themselves in different populations. Diana identified some children need nutrition, some, you know, different things. but every school needs to have a plan, and they don't have the resources for that. That plan has to come, again, so much is relied on Central District Public Health, and frankly, you guys don't have enough resources, but they're going to need a plan. And assuming Central District Health has the resources, they can provide that resource. And there are certainly pediatricians and American Academy of Pediatrics who can also offer advice. But I think the two aspects would be, one, positivity rate less than 10 and going down. And number two, a clear plan. And that plan has to be all those different aspects that I described, along with what do we do with a positive case? And and as long as I'm king, oh, for goodness sakes, I'd hire more people for the Central District Health to do the tracing and to help. Oh my goodness, yeah, I'd like more school nurses, and we could solve the testing problem.
Don't get too big for your britches.
Thank you. That's a nice. Thanks. Nice wrap up.
And Ted, thank you very much for your service on the Central District Health. All of you, thank you.
Well, thank you, Dr. Peterman. On behalf of our board, it was very informative, and we may be asking you for input as we go forward towards school reopening.
You're welcome. And I whether Diana likes it or not, and Ted, I've been sending them regular updates, and I'll continue to send it to them weekly, and then they can share it with you guys.
Okay, thank you. Much appreciated.
All right, thanks. I think I just X out of here and it'll work okay. So thank you very much.
Well, thank you. Okay,
stay healthy.
moving on from Dr. Peterman's presentation, we will have a discussion and vote regarding potential actions to protect the life, health, and safety within the district as to the COVID-19 pandemic, including potential amendments to current public health orders for Ada County and consideration of orders for other counties or communities within Public Health District 4. So the floor is open.
Madam Chair, this is Diana.
Yes, Diana, go ahead.
So I'm going to try and wrap this all together. I want to follow on the schools question because I know we've received a lot of emails. Russ has gotten a lot of questions. So maybe we'll start out with some, Russ, if you could clarify for the group and by way of that, the community, what is the decision-making process on when and how schools reopen? Could you start out kind of with that framework for us?
Sure, Madam Chair.
Yes, go ahead, Russ.
Yeah, so essentially our staff, as Dr. Peterman mentioned, have been working very closely with all of the schools, school administration, school staff throughout our health district since the very start of this back in the middle of March. And we've produced guidance that has been adopted on a statewide basis in partnership and collaboration with the other public health districts and the Idaho State Board of Education. So the State Board of Education, the Governor's Office, Department of Education, Department of Health and Welfare. So point with naming all of those plus the health districts. We've been working on this knowing it's a huge deal. For our public health district, we have over 75,000 students who will be heading back to school, if that is to be, here in about 1 month. The idea of not starting isn't in the plan right now. That would be based on community transmission, and that definition of community transmission in the Idaho State Board of Education's Idaho Back to School framework. So they put a framework together, well thought out. It covers a lot of the issues that we've already discussed as far as food service, transportation, at-risk population, staffing considerations, preventive measures that they need to take, what happens when one student is sick, what happens when multiple students. So just wanted to make you aware there is a very well thought out structure that's already in place. Now, those are guidelines. So that's a guideline that is given to the schools. So just like I work with all of you for the operation of Central District Health, each school district also has a school board. So their administration will be working closely with their school board to make sure that these guidelines are implemented in so much as they can, and then operating within the parameters based on community transmission. So category 1 is essentially none. And as has been pointed out by the governor a number of times, we still have large geographic areas in our state, a county, for example, without any cases or very few cases. So the statewide approach, in my opinion, is not the best way forward. I do think the local control is really important, and that is directly relatable to what I'm talking about with schools. If Boise County, for example, Basin School District, they have no cases in Idaho City, they shouldn't apply the same exact standards or closures or online only as here in Ada County. There's almost no question we're going to have at least minimal to moderate transmission here in Ada County ongoing. I don't foresee that changing short of stay home orders. And I think that's highly unlikely to happen. So our role is close consultation with the schools, which we have maintained this, I think, a great relationship with them, as I mentioned from the start of this, and continue that relationship. We're going to have a public information officer. We're actually bringing on board specifically to primarily work with schools and handling all the public communication aspects, which are also part of that back to school framework, by the way. We also have a team of epidemiology staff. So these are various levels. You have the high level epidemiologists like our Kim Link and her normal staff, the staff who work on communicable disease day in, day out. Plus we brought on other high level staff. And then we have, I guess I call them steps down from there as far as the level of education that's required to do things like contact tracing. So that's all being organized right now in prep for the inevitable, which will be kids are going to be at school. They're going to test positive. They're going to have exposed classmates, staff, school bus drivers, et cetera. So I feel like the structure's in place. Clearly decisions have to be made. And I mean, I want to bring this up, right? You all have made a decision starting on June 24th of implementing community mitigation strategies, no doubt affected businesses. Nightclubs and bars were closed and they haven't been open since. Restricting gatherings, restricting visitation to long-term care facilities and Department of Corrections. So some of the next questions are, and Dr. Peterman brought that up. Okay, dine-in restaurants are still allowed in Ada County and throughout the state. So if our case counts remain as they are today, do you say schools should be closed, but dine-in restaurants should continue and gatherings of 49 or fewer should continue? So that's why I think it's really important to have these meetings weekly, is to continue these conversations. Face coverings, we've talked about it a number of times. There's more and more evidence to show that they work. Now we need to talk about that with our orders as far as the inclusion of schools, K through 12. Does it include just public, charter? Does it include public, charter, and private schools? A conversation we need to have certainly before 1 month from now. So in conclusion, I feel like we have a really strong team ready who has been supporting schools, will continue to support schools. The one area that still needs to be defined, and that's being worked on right now with our staff. And when I say our staff, I mean all 7 health districts and the State Division of Public Health, on what does minimal to moderate community transmission mean? What does substantial community transmission mean? And then are you going to define that by a geographic boundary of a school district, a county, a health district? And we're still working through those details, but hoping to have something out. Definitely ready for more comment by next week.
Thanks, Russ. Could I follow up to that, please, Betty Ann?
Yes, go ahead, Diana.
Well, the conversations that Russ and I have had with school districts over the last week was as it relates to face coverings and schools. And having spoken with, I personally spoke with superintendents in Boise and CUNA, and I know Russ's staff has spoken with us, West Ada, which cover both, our Ada County school districts at least. They are all currently interpreting the order we did last week to include schools. But I'm just wondering, Russ, if you have a sense that we need to further clarify that order, or what's your take there?
Madam Chair?
Yes, go ahead, Russ.
Yeah, it's a great question. My thought on it is, and Dr. Epperly in our communication as well, it was his intention to include schools. Our legal counsel has said, yeah, the way the order is written, it does include schools. My recommendation is it needs to be crystal clear. And the way I read it now, as far as public place, which is what the mask orders apply to, open to all members of the public without specific invitation. So I think it needs to be clarified. We have a lot of time to do that. That would be my recommendation to the board.
Okay.
Madam Chair, this is Elt.
Yes, go ahead, El.
Russ, are we ever going to reach a point here pretty quick where we limit the crowd size to say 20 or 25? I mean, I think we're making a huge mistake at 50 right now. But my concern is, okay, if you have a classroom of kids, you can only have 24 kids. And let the schools figure out a way to do that. I don't know, just an idea.
Madam Chair?
This is Jane.
Madam Chairman, Mike Kane here. Can I get in on that question?
Yes, Mike, go ahead.
I would like to remind everyone that the way the order reads right now as to public places and wearing masks, that if you can have at least 6 feet apart from each other, masks are not required. So as we work into the questions like, well, can you have 20 people? Can you have 40 or 50? We can't forget that we're telling people that if you can do social distancing in public places, at least as far as masks go, they're not required.
Yeah. To that end, I think just kind of circling back to the schools piece, again, they've been working really closely with Russ and team. They have already adopted a number of different plans and strategies that incorporate some of the things that Dr. Peterman suggested. I think that question is the key one. What needs to be worked out? What is minimal to moderate versus substantial mean? And we have a lot of anxious people wondering about that. The other piece I would just share with you all is that my conversation with the school districts is that they were very grateful that we did this on a countywide perspective. They were already feeling like they were in a very difficult position, having to make this decision either at the school level or at the school district level. So it allows them to just do what they need to do and focus on being educators, with all these other pieces in mind. So I guess, Russ, I'm asking, if you feel like we need to make it crystal clear, would you have some proposed language and we could adopt that next week? What's your suggestion there?
Madam Chair?
Yes, Russ, go ahead.
Yeah, my recommendation is that I will draft language. We can post that on our website like we have with other draft orders and have the board consider it next week for adoption. And that will give the public more opportunity to provide input as we have offered through the email link that's also published. And I'll work with Mike Kane on that just to make sure, like I said, it's crystal clear. And we have enough of a runway. I know some schools have activities going on right now, but the bulk will be starting in a month from now.
Thank you. Jane.
Madam Chair.
Try to weigh in. Jane.
Madam Chair, this is Megan.
Oh, hi, Megan.
Chair. Can you hear me?
Yes, we can hear you well.
May I ask a question, make a comment, please?
Yes,
I just want to say, in the interest of clarity, if we're going to look at clarifying the decision, can we also start looking at some very clear guidelines as to when a potential mask order would be lifted, particularly if you're looking at what is going to determine numbers for community spread? Because I think the lack of clarity there is also very confusing to the public.
Betty Ann, this is Ted Epperly. I'd like to ask a couple questions and make a comment too. Russ, with the categories 1 through 3 that the school guidelines are contemplating, you made it clear category 1 was no community spread or transmission. That one's kind of a no-brainer, obviously. Am I understanding that category 2 and category 3 is what you're talking to about moderate and substantial, and they're looking to us to define either like positivity rates, like we just discussed? Is that what they're looking for from us in regards to helping them define category 2 and category 3?
Madam Chair?
Yes, go ahead, Russ.
So Dr. Epperly, what we're doing is working with the state, like Elke, Dr. Hahn, and some of her staff actually to define that. So no, we wouldn't be looking to the Board of Health or other boards of health to define that. We're working to try to narrow that down so that it is clear what criteria we're using. And then the public health districts, myself, will say we have, just like we have all along, we have no community transmission, then we have community transmission, except what this will look like is CDH will declare community transmission likely on a county by county basis once we figure out exactly what that criteria is.
So, Ann, just to follow up then to that.
Yes, go ahead.
One thing that maybe from this discussion, Russ, that we can take back to the division or Department of Public Health within Idaho Department of Health and Welfare, and to Elke Shaw-Tulloch and to Chris Hahn, might be a clear dividing line at 5% and 10%. It could be that category 2, which would be moderate community spread, is greater than 5% but less than 10%. And substantial community spread is greater than 10% and higher. So just point 1 on that. That could be some data. Obviously, we could, and I'm sure you're doing this, or the Department of Public Health at the IDHW, is, we can see what other states are doing in terms of that percent. That could be something that could be applied fairly easily. The last point I'd like to just make, I think in terms of helping clarify the order around face coverings, would be that I like the idea, Russ, of you further working on some draft language. That way the public can see what that is. We can look at that and act on that at our next meeting. But I'd just like to make a couple points that I think needs to be in there. I think that the face coverings should apply to all schools, public, private, charter, any place where there's going to be a gathering of children in a closed classroom in any way, because of just the things we've talked about for the first hour of this meeting. They're going to be at great risk for transmission back and forth. It's going to be an issue. So anything we can do to help mitigate that will be helpful. So face coverings, I think the extension of that to schools, both public and private, charter, I think it should apply globally. And again, within counties where we have high transmission rates, of course. Boise County, if it has no transmission rate, although I know there are cases in Boise County now, but certainly it wouldn't apply to. The second and last point that I'd like to mention, and Mike Kane actually framed this one, I think, and that is, as it stands now, the order of being socially distanced by greater than 6 feet would require no mask. I think that's going to be a problem in the schools. And the reason I do is because of this airborne transmission issue that we talked about in the conversation with Dr. Peterman. There's more and more and more data around airborne transmission. We take masks off because we can socially distance in a school classroom at 6 feet. All these kids are still in a closed container with circulating air in the school in the winter time. It's going to be a risk. So I think that one thing you could consider, Russ, is to broaden the mask face coverings to all schools, and that because of the airborne transmission issue, that in schools, the 6 foot distancing doesn't apply. In other words, it should be masking in schools at all times. And I'll stop.
Madam Chairwoman.
Of course, the exception
Go
could
ahead,
be
Megan.
for eating.
Thank you, Madam Chairwoman. I just really want to express again that there's a great deal of uncertainty going on here. And while we're willing to clarify the order, we're not willing to clarify what mandates the order, what metrics we're going under, whether we're talking about community spread, whether we're talking about hospital admissions. There's this whole vagueness as to why the orders are necessary. And I think it's really important going forward that we provide some pretty serious clarity. I'm very concerned that we worry too much about clarifying an order and placing in mandates, and we're ignoring the problem of not providing clear targets for the public on when these mandates are lifted. I mean, there's people whose businesses are at stake. I understand we have serious health concerns, but those are concerns as well. And for as much stability as we can provide, we need to do it. And I'm concerned that we're not looking at those levels. And if we can provide clarity based upon community spread stages and giving actual metrics to those, that would at least be something, because at some point we had all talked about this isn't necessarily about nobody getting sick, it's about overwhelming our hospitals, but we continue to have difficulty getting data that shows trends and what the projections are there so that we can have good decisions made. And I just want to make sure that we don't lose that focus too, that while you want the order to be clear and you want cooperation, to get cooperation, you need to provide clarity as to why people are doing it. And I have real concerns that we're not.
Madam Chair, this is Diane.
Yes, Lana.
I think that's really fair. And, you know, Russ and I have been meeting actually with all of our elected mayors, as well as the emergency management team, paramedics, et cetera. We meet twice a week. We have the on those calls. And this is something that we are, it's a work in progress, I'll tell you, because some of the initial data sets that we have had, we've learned are not as applicable to what they are seeing and feeling on the ground. So, you know, we're getting, for example, we've been getting ER hospitalizations related to COVID. Well, now we're learning that so many of these folks are direct admits. They're not necessarily coming through the ER. So, I am very hopeful that we are homing in on some better data sets that will give us a clearer picture of what we're verbally hearing from the health systems. As I said last week, I don't think they could have verbally been any clearer about what they're seeing and feeling, but I echo your thought that we need some visuals and data sets so people can follow along with us.
Thank you. If I may weigh in, this is Chairman Nettleton. I would like when Megan was talking about clarity, to address in our draft order, we have children under the age of 2 are exempt, Dr. Peterman, of course, addressed today the American Academy of Pediatrics uses 5 years of age. Another thing we need to think about when we're talking about this as, charter schools, private schools, public schools, is we haven't said anything about daycare. Thoughts on that?
Well,
Again, this is Ted Epperly.
Yes.
Again, we a couple things. We know kids can be asymptomatic up to 33% of the time or so. We know that they can transmit to people. I think from a public health perspective, we do need to be hopefully preventive and proactive enough to try to help mask and face cover as many potential people that are going to be in harm's way and prevent downstream infection as possible. I think the CDC guideline is for 2 or less.
Right.
I recognize how difficult that can be in a 2+-year-old or a 3-year-old or a 4-year-old, but it brings right to the fore your question, Betty Ann, about daycares. And I think that we should do the best we can to make sure daycares are also considered. The last point I just want to make is in reference to Megan's plea for clarity, and I think we should be as clear as we possibly can with this. The state has already adopted, and the governor's Rebound Idaho plan, both clinical and syndromic and epidemiologic data for stage openings, et cetera. I think the one thing that we could potentially ask in addition now for clarity around this is the percent positivity rate in the community. That was Dr. Peterman's big thrust today. And if we were to use some categories at 5 and 10%, that could help from a clinical perspective have further clarity to what constitutes community spread. Without it, we may be missing a big chunk of what's happening in the community. In other words, if we just use ER data, not everybody's going to the emergency room. In fact, it's less expensive not to go to the emergency room. It's much better and cheaper for people to be seen in clinics in the community where their usual source of care is. So I think we've got to include that. So those would be some of the things I think that we could potentially suggest around the school plans would be, of course, epidemiologic, clinical, syndromic, but also this percent positivity rate in the community, and I'll stop.
I agree with Megan on coming up with some type of end conditions, stopping conditions for the mask order. One thing that I would like to see, if at all possible, next week is, can we get some senior educators on the call? We haven't heard anything from the schools. The superintendents, I understand that they're talking to Diana and Russ a little bit, but they're not talking to all of us. And I think that it would do the board good to hear what their thoughts are on it, to be able to ask them questions, find out what their plans are, what their options are for working through any type of an infection, what they're going to determine for when they have lost control, per se, of a possible infection. Because one of my biggest concerns with school and everything opening back up is, I want my 16-year-old to go back to school. I am not a good teacher, but at the same time, I don't want to open a school to have it be open for 2 weeks to shut it down, or have it shut down on its own because it has some kind, an outbreak, and they can't they can't function, they can't, that there's no teachers, and there's a plethora of things, right? And I think that there's a lot of questions that can be asked directly to a senior official of the school, like a school board president or someone like that, superintendent, anyone, that we would be able to talk to them and say, hey, these are our questions, these are our concerns. What's this going to look like if you get, like the question I asked Dr. Peterman, what are you going to do if you get one kid in there? What's that look like for your school? One kid that rides the bus from West Ada all through the bus route and then ends up at school and has been sick. What does that look like? What does it look like for a kid that comes to school who's immune compromised and then goes home and has 60-plus-year-old parents who are also immune compromised? What does that look like? And I don't feel comfortable even I mean, I know it's not really on the table today, but I don't feel comfortable making a decision, A, regarding a school, and B, without having that information and knowing that this is what we're getting ourselves into. If we piggyback on this and make this a decision that we're willing to endorse.
Madam Chair, this is Russ.
Yes, Russ, go ahead.
I think Commissioner Sturm's suggestion is a great one, and we don't have anyone lined up to speak next week. And I can talk to probably the Idaho State Board of Ed, working through them to find somebody through one of the school boards or school administrators, school superintendents who would be comfortable and well-versed in the subject, and have them talk just like we've had over the last couple of meetings, if that would be acceptable to you.
Yes. Any further discussion?
So, Betty Ann.
Madam,
Yes, Jane, go ahead.
I just had a really quick question. When we're talking about the positivity rate, are we saying that the 10% positivity rate is 10 out of 100 would be positive?
Madam Chair, this is Ted Epperly. Yes, Jane, that's what David Peterman was implying, is that for 100 tests done, 10 would be positive. So when he was presenting his data on positivity rates in the community, the numerator was positive tests and the denominator were all people tested.
So if 33% of the kids are asymptomatic, that puts us up to like 45% of kids that are able to spread it?
There are two different things. So the 10%, 5%, 15% would just be the total cases in the community, adults, older people, younger people, all of them. And that was his data, was all age groups mixed into one, that percent positivity. It wasn't broken out when he was talking about the positivity rate into specific categories. It certainly could be if we wanted to make it school specific. The 33% potential asymptomatic rate really is the frightening figure, because what that implies is that it's already at 5 to 10, 15% in Ada County now for positive rates. That's in known people that have been tested. For every positive case we've had, and this is the frightening thing, there are probably 6 to 8 more people out there that we don't know have it because they're either asymptomatic or minimally symptomatic. And that's the problem, is that you get a school full of potential kids that have mild to no symptoms. It could just be a runny nose, like happens again in the winter time. And without the ability to test every single one, we just don't know. And so it leaves schools in the lurch around what to do with a runny-nosed child, which is almost happens to all kids at least once through the school year. So that's why this is a big conundrum right now, and I'm glad we're talking about it, and I'll stop.
Hey, Betty Ann, this is Representative Blanksma.
Yes, go ahead.
Thank you, Madam Chairman. We seem to be running over the same ground, so I would make a motion to adjourn.
Madam Chair, this
Okay,
is
the motion
Diana. I did have an additional point I wanted to bring up, and then I think we'd be on good ground unless there's
Okay, go
other
ahead,
things.
Diana.
So, as I
Go ahead.
shared, we've stood up. We've had our emergency operations center running since March, and we have these twice weekly calls that Russ and I are on with mayors, et cetera. And it's similar to this meeting, we have different folks bring things in. And one of the really frustrating and maybe shocking things that was shared this morning was one of our hospital systems shared their internal modeling in terms of what they think the impact to their health systems is going to be over the next couple months. And included in that modeling are any mitigation efforts that we have undertaken and lack of mitigation efforts elsewhere. And I think as we're seeing this, we are seeing this play out in real time where we have the Meridian ICU full in St. Luke's, the Nampa ICU full in St. Luke's today. St. Al's had already said last week they had to stop cohorting just in Boise. Now they're cohorting in Boise, Nampa, and as of this morning, Ontario as well with COVID patients. And I'll just share in my own life, I've shared with you before, my husband is a primary care internist. He hasn't worked in the hospital in more than 5 years, but he was just asked to go work in the hospital in Nampa. So this is happening in real time, and I guess what I want to put out there is based on the modeling that I've seen, we can't do this alone. Ada County cannot do this alone. Central District Health cannot do this alone. Our health systems are all intertwined, and while I certainly appreciate Dr. Peterman's concerns and comments about, do we need to further limit things in terms of restaurants, et cetera, in Ada County, absent our, fellow neighboring county taking any mitigation efforts, I just think that would be I don't think we'd get where we'd need to from a health system perspective. And I also think it's very fraught and unfair for our local businesses. So I don't have an answer to that, but it's very frustrating and concerning to me given what we're seeing, and hopefully we'll start to see some perhaps different movement next door.
This is Chairman Nettleton. If I just may weigh in on a point from Elmore County, I have been very pleased at the responsiveness in Glens Ferry. We've been in contact with the mayor down there. Both of our grocery stores mandate masks, and now in Mountain Home, of course, everybody is aware that Walmart and Albertsons have mandated masks. So we feel very fortunate that those major traffic businesses have done this, and our numbers are, pretty stable. So any further discussion before I ask for, is there a second to Megan's motion? Hearing none, do I have a second to the motion?
This is Commissioner Hasbrook.
Fails.
I'll second that motion. I think we've run
Okay,
over
the
this
motion
turkey
has
enough
been
today.
made and seconded. So I will call for a roll call vote, starting with Valley County.
Hasbrook, aye.
Ada County.
Jane Young, aye.
Jane Young. Ted Epperly.
Ted Epperly, aye.
Commissioner Lacchiondo.
Diana Lacchiondo, aye.
Boise County, Commissioner Sturm.
Commissioner Sturm, aye.
Elmore County, Representative Blanksma.
Representative Blanksma, aye.
Okay, motion passes. Therefore, our meeting is adjourned until next week, which will be the 28th at 4 o'clock. We will be online again, and hopefully we'll have some more education input. So I thank everybody and the public that has listened in for your participation. So have a good week. Stay safe, everybody. Bye now.